Health Sciences, which is a brainchild of the friendship that has been centuries old between India and Nepal. And when our former Prime Minister, Mr. Chandrasekhar, visited Nepal in early 90s, at that time, a, an MOU was signed that India and Nepal will join hands to have an Institute of Excellence at Nepal. It was as a result of that MOU that BP Koirala Institute of Health Sciences came into existence in 1994. And I must share with you that at that time, three institutes were primarily chosen from India to facilitate the entire program. And one of the institutes, in addition to All India Institute of Medical Sciences and PGI Chandigarh, was University College of Medical Sciences, where I've been working for the last 32 years. And in fact, the principal of the college, Professor K.N. Sharma, after his retirement from UCMS, joined at BP Koirala Institute of Health Sciences, where he was the project director for the and chair of the Project Implementation Authority for 5 or 6 years. And that is how I learned about BP Koirala Institute of Health Sciences. But the first contact with BP Koirala Institute of Health Sciences was once my wife actually visited that institute, because 93 the MBBS course started, sorry, 94. And my wife visited the institute in 96 and 97 again, when she was invited to give a blueprint and the concept plan for starting the dental college over there. And thereafter, when an interview was held in Delhi in the Embassy of Nepal, I went over there to appear for the interview in 97. And after getting appointed, I joined at BPKIHS for 2 years as a professor and head of medicine department. I must tell you that those 2 years were really a great learning experience for me. And in fact, all those memories of those years, they come back to me. In fact, this was the first time. And especially, I'm so happy that Dr. Ved Prakash Mishra is also here with us. I learned about how and what an innovative academic curriculum program is there. In fact, this was the first time I really came across a different type of teaching program where the curriculum was horizontally integrated, vertically integrated. The teaching was organ system based, and it was focused on OSCEs and OSPEs and problem based learning. I learned quite a lot of things over here, and how really to really teach the MBBS students in an innovative way. In fact, uh, at that time, the PG program, of course, had not started, but I was instrumental in framing the curriculum for the MD program in medicine, and also to some extent for the MBBS curriculum program also. The vision and mission statement of BPKIHS had just been finalized before I uh, joined over there. And it is relevant in the context of today's seminar on bioethics, because if we look at the vision and mission statement of BPKIHS, it very clearly states in its preamble that the main aim of BP Koirala Institute of Health Sciences is to create doctors who are compassionate, caring, communicative, and socially accountable with ethical values. I must say that during the entire training of MBBS students over there, great care is taken for making sure that the students who are trained over there, they are very caring and looking after the patients in a very holistic manner. Not that they are treating tuberculosis or diabetes in a patient, they are treating patients in a holistic manner. I'm very delighted that a Nepal unit of bioethics has been established over there. I remember in October 1998, when BP Koirala Institute of Health Sciences was upgraded to the level of university, and it became a full-fledged autonomous deemed autonomous university. And at that time, the Prime Minister of Nepal, Mr. Bhattarayaji, and our Foreign Minister from India, Mr. Jaswant Singh. They were there to on the occasion of inauguration of BP Koirala Health Science Institute as a university, and it was at that time that one of the journals, actually multi-speciality journal, which I was given the responsibility to start as an editor, it was also this journal was also inaugurated by the Prime Minister of Nepal. I was also lucky that I could start a hemodialysis and peritoneal dialysis unit, which was the second unit after Bir Hospital at Kathmandu to come up in Nepal. And thereafter, Dr. Sanjeev, he is still there as head of medicine and a very highly trained and committed nephrologist. He has been working over there for the last 25 years. I'm also remembering my very dear colleagues who were there with me, including Dr. Prahlad Karki, Dr. Rupa Singh, Dr. Sudha Agrawal, and C.S. Agrawal, Nirmal Baral, and so many other people. Of course, Dr. Shekhar Koirala, who was the rector and the founding vice chancellor of the BP Koirala Institute of Health Sciences. He was a great visionary. And I feel that whatever this institute is, it is because of the hard work put in by Dr. Shekhar Koirala. Sorry, I am remembering all those things and at this occasion, but it has been, I think, one of the wonderful period of my life. Those 2 years when I spent over there, I mean, I really learned a lot of things as far as the teaching learning activities are concerned, particularly with an innovative kind of curriculum. Thank you once again, Dr. Russell, for giving me this opportunity to join this platform with the faculty from BP Koirala Institute of Health Sciences. And my congratulations to the entire team for putting in a great effort for organizing this webinar. Thank you.
Thank you, O.P. Kalra. Thank you very much for that, taking us down history lane. We have a history too, but much later. My history is only from 2013, December. So you take us back further down. So,
in fact, Dr. Ved Prakash Mishra might be delighted to know that when the first batch of MBBS was appearing in the exam over there, the MCI inspection was to be done, and Dr. Ketan Desai himself came over there. And the health minister of Nepal also came over there, who had been my senior resident at PGI Chandigarh when I was studying. And later on, he became the president of Nepal, the first president of Nepal.
So here we have a good history. Dr. Dana, you have a good history today from time before you came, right? So bioethics has been a UNESCO program through Dr. Kalra, through myself, through Dr. Ved Prakash, and now through Mary and Dr. Professor Mary. We've been all united in this endeavor. So congratulations and all the very best in your in all what you all are doing for the future professionals of this who are going to serve your community and indeed the community in the world. Thank you.
Thank you, sir.
So I'll hand it back to our moderator, Professor Sami.
Thank you, sir. Thank you, Russell, sir. And thank you, O.P. Kalra, sir, for reminding us after this history of BPKIHS, and we have always been cherished with your significant contribution in BPKIHS. Thank you, sir. So now let me help invite Professor Dr. Sibendra Jha, sir, Dean Academics, BPKIHS, who has always been support for us in every way to address the gathering on behalf of BP Koirala Institute of Health Sciences, Nepal. Sibendra, sir, now floor is yours, sir. Sibendra, sir.
Thank you, Sami ma'am. Thank you very much for giving me opportunity to welcome you all. And Kalra sir, good afternoon. It was really wonderful to listen the
Good
historical aspect, which we are not aware of. I joined BPKIHS. I came to BPKIHS as a student in 1999. So you told so many things about the history before that. And I will gladly share with you, sir. You were legend and student who are studying MBBS, who has done PG in medicine. They still talk about you, and we still remember your contribution, sir. And if you won't, I think one thing I would like to add. Probably your son was here, sir.
Yeah,
Sarthi.
yeah. I
So
forgot about that.
you
My
told
son also did his MBBS in 2003. He joined MBBS.
New
so I was
Generation
in hostel.
Association.
I was in hostel with him. That's why I thought like I don't know deliberately you
So
didn't mention or
he has been your student. No, I forgot about him. He's in USA now. He's
yes,
in
sir. I know,
US.
sir. I'm in touch with him, sir. You don't know me, but we all know you. We all
Very good.
respect you, and we are very thankful for all your contribution in the beginning, sir. And it was really wonderful to listen. Like I was listening every word you said, and it's like more than many people staying in BPKIHS knows about BPKIHS, sir. So thank
Sir,
you very much for loving our
I
institute
will
to that
just
extent.
share one thing with you that as an MBBS student, when he was undergoing his training at BP Koirala Institute of Health Sciences, he worked on 7 research projects,
Yes, sir.
including 2 case reports. So I think this is what has actually taught him what research is. And today he is assistant professor emergency medicine at University of South Alabama, and he's also director research over there. So his first lesson of research came from BP Koirala Institute of Health Sciences. That is where the foundation matters. We are very grateful to the institute.
Thank you, sir. Thank you very
Yeah.
much. Thank you very much.
Thank you. Sorry to come in between. Yeah.
So thank you very much for giving me opportunity to welcome you all in this program organized by Nepal Unit of UNESCO Chair in Bioethics BPKIHS in association with the Department of Education International Program of UNESCO Chair in Bioethics. It is indeed a matter of great pleasure to welcome you all on behalf of BP Koirala Institute of Health Sciences, Dharan, in this international seminar series on bioethics and COVID-19 pandemic. This is such a great platform where I can see almost more than 300 participants, and those participants are increasing from across the globe to discuss one of the most important issue of the health sciences in the present time, that is the bioethics. Since its inception from the year 1993, the UNESCO Bioethics program has been doing tremendous work in the field of ethics and human rights. More so in capacity building and increasing awareness and education in the sector of the bioethics. With advancement of new technology and ideas in the field of medical sciences, so much dilemmatic situations are being noticed in this field, which has been increasing day by day. So the branch of bioethics has been showing path in all those dilemmatic situations. And now with the emergence of this COVID-19 since last year, the role of bioethics has become much more important than what it used to be. The extreme contagiousness of the disease, lack of much knowledge about the disease, the scarcity of resources for the treatment of the disease, and the fear from the disease throughout the globe. These are the factors which has made the situation much more complicated than for any other disease mankind has seen in recent times. Therefore, the role of the bioethics has been and will be much more crucial in the near future, and seminars like this has become much more relevant. I'm extremely glad that Nepal National Unit of UNESCO Chair in Bioethics, since its inception from 2013, has been continuously involved in organizing and participating in different seminars, workshops, awareness weeks, quiz contests, essay competitions, curriculum development, sensitization programs, and lots of publication in the field of bioethics. So on the behalf of management of BP Koirala Institute of Health Sciences, I would like to say that full cooperation is there for the bioethics from the institute, and whatever help will be required in the near future for the development of this unit, institute is always there to extend its help, and all of us with combined effort, we will be trying to fulfill all the objectives. So again, I would like to welcome you all in this program in the presence of all eminent personalities. I would like Professor Russell D'Souza sir, Professor O.P. Kalra sir, Professor Ved Prakash Mishra sir, Professor Principality ma'am, Professor Mary Matthew ma'am, Professor Dhanaratna Sakya sir, and Professor Sami Lama. It's pleasure having you all at one platform. And as I told, during this COVID pandemic, the importance of bioethics has drastically increased, and with the presence of all eminent personalities, we will have a very fruitful discussion, and I wish extreme success of this session and the enthusiasm of the participants. I welcome all participants also. It is very happy to see their enthusiasm, and at the end of this seminar, we all will be having a clear-cut picture, and it is going to help in our decision-making processes. It is going to helpful in knowing the bioethics in a better manner. And at the last, I would like to say it is the love and empathy which has much more effect on the patient. Any advancements without love and warmth doesn't have and will not have complete positive impact on patient. So we all should be having the warmth and love towards the patient. Ultimately, that is going to do much more magic. With this, I would like to say, have a nice time, have an informative time, all of you. And big thanks to you, D'Souza sir. You are always there. It is you due to whom our unit has been established here. So keep on blessing us like this only in near future also. Thank you very much. Thank you all.
Thank you.
Thank you, sir, for your word of appreciation. Thank you. So now let me invite Professor Dr. Dhanaratna Sakya, Head Nepal National Unit of UNESCO Chair in Bioethics, and also Chair of today's webinar, to present the report on activities of Nepal National Unit of UNESCO Chair in Bioethics. Dharatna sir.
Thank you, ma'am.
Over to you, sir.
Yeah, thank you, ma'am. Okay, so thank you, ma'am. Let me thank our member secretary and past chief of the College of Nursing, Professor Sami Lama ma'am, for moderating today's program despite of her very unavoidable work also. So actually, I am very much touched by the unconditional devotion, contribution, and support that all of our unit and student members offering to the bioethics mission set by the Global Network of UNESCO Chair. Myself, Anaratna Sakya. So currently I am the professor of psychiatry in BP Koirala Institute of Health Sciences, Dharan, and currently the head of the Nepal National Unit of UNESCO Chair in Bioethics, coordinating this Nepal International Seminar of Bioethics and COVID pandemics. Head of Asia Pacific Division and head and chair Department of Education of UNESCO Chair in Bioethics, Professor Dr. Russell D'Souza sir, our very respected Professor O.P. Kalra sir, Pro-Chancellor DMI MS Deemed University and Health National Academic Indian Program UNESCO Chair in Bioethics, Professor Dr. Ved Prakash Mishra sir, Integrated Curriculum UNESCO Chair in Bioethics Head, Professor Principality Ma'am, Head of the Indian Program UNESCO Chair in Bioethics, Professor Dr. Meru Methu Ma'am, the Dean, our Dean Academics, Professor Sivendra Jha, Dr. Derek D'Souza, respected and active participants from within Nepal and across the globe. I see many names there, including Professor M.P. Deva from Malaysia and all faculties from BPKIHS and other institutes of Nepal and other countries, civil society, global network unit members, our steering committee members, Dr. Ravi Ram, Dr. Sangaratna, Arpana Rizal ma'am, B.N. Yadav, Dr. Sarun Koirala, Dr. Ashok Ayer, Kane sir, staff, teachers, dear students, our current student wing head, Mr. Ayush, and secretary, our beloved Sasanka, and all student wing members of the BPKIHS, and also recently formed Nepalganj Medical College. Media personnel, ladies and gentlemen, namaste and welcome to all of you, personally from me and also on behalf of our unit. Here in our part, we are in the festival season amidst the COVID pandemic. So we have just celebrated the Vijaya Dashami and we're welcoming a series of the festivals. So let me also wish you all of you happy Deepavali, happy Chhath, and happy Nepal Sambat. So this is a very original from our country. That's the year of Nepal Sambat, 1141 Nepal Sambat. So this year, stay safe and stay blessed. Today, we are gathered here after the celebration of the World Bioethics Day 2020 in October 19 for a special event that is International Seminar Series on Bioethics and COVID-19 pandemics. As a national head and as a national head of the organizing unit and the coordinating event, I must express my sincere gratitude to our respected Professor Dr. Russell D'Souza sir and the whole team of the Department of the Education of the UNESCO Chair in Bioethics for everything they have provided to make this event, and our respected Professor Dr. Amnon Karmi sir, so head of the UNESCO Chair in Bioethics, for his blessing and kind words. I feel honored to welcome all of you in this important seminar series and present the report on the activities of our unit, Nepal National Unit of UNESCO Chair in Bioethics, as the head of the current executive committee and the one involved since its inception. So I remember the very moment when our Professor Dr. D'Souza approached me in the 4th World Congress of Asian Psychiatry in Sri Lanka in 2013. I was attending the event as an invited speaker, and he proposed about the establishment of this Nepal unit. And it was the seed, actually. It was the seed of our unit that I carried with me to my country and tried to plant, water, and nurture every way possible for our context since then. For this, I approached the Institute authority and I must acknowledge the then rector, Professor Dr. Bikram Prasad Shrestha sir, so who took keen interest, and we too sat together for hours to fill those long application forms and letters and to explore the possibilities to support its establishment and a smooth running from the side of the site institute it can provide. I was actually proposed as a head in the application and applied by him. I suggested Professor Dr. Rupa Singh ma'am as a head, and I contributed as a member secretary in the first committee. After ma'am's retirement in our institute in 2017, I have been working as a head and Professor Sami ma'am as a member secretary, and we have 13 members from across the country in current committee. Today, I would like to highly appreciate Professor Rupa Singh and all members, including Professor Suman Rizal, Professor Sibalal Sharma, Vipulendra Chakrabarti, Chandra Prakash Pandey, NHRC executives, and all for their tremendous contributions throughout. So in December 16, 2013, Nepal unit at BPKIHS Dharan was approved at the Nepal's conference as the member unit of the network of the UNESCO chair in bioethics. This very unit acts as a facilitating body in Nepal, mainly to disseminate, improve, and monitor the education in ethics in medical schools. In collaboration with this Asia Pacific Network Steering Committee, it has been a resource to plan and initiate the agreed initiatives of bioethics in Nepal. So since then, this Nepal unit has been trying to organize various activities. So in this slide, we can see the glimpses of that very glorious moment for us. So in 2013, it was established, and in 23rd of the January of 2014, it was actually formally inaugurated, and it was marked by international seminar on the bioethics. So since then, Nepal unit has been trying to. So here, and since then, Nepal unit has been trying to organize various activities, programs, and day celebration along the mandate of the UNESCO Chair on Bioethics and its networks to raise the awareness about bioethics and related issues. So far, Nepal unit has been able to organize international seminar, national curriculum workshop, and other programs like CMEs, seminars, quiz, etc., which we believe have been here in this line. So after the establishment of this student wing, in BPKIHS, our unit has been conducting various student-focused programs considering their needs. For example, sensitization program, where the faculties orient them with the introductory lectures and the group works, and a regular seminars based on the bioethics curriculum, quiz contest, and essay competition. In these seminars, students present on the topic, guided by our faculty, and the faculties reflect and discuss in the seminar. So we organize essay competition. Even during this COVID breakdown period, with the theme of ethical issues during COVID-19 pandemic, and there was a overwhelming participation, not only from Nepal, but also from India. So we are putting our efforts to extend to as many other institutes as possible, and recently we have other student wing in other corner, that is western part of the country, that is Nepalganj Medical College. So we have another student wing besides in the BPKIHS, that is in the Nepalganj Medical College. We're also putting efforts in the research and publications on the bioethics. So in this slide, we have tried to depict some of those efforts here. In the same continued, so this is one of the papers that we produced. And in the same continued effort, our unit takes the World Bioethics Day celebration as an important occasion for raising awareness. We are happy to share with you all that our unit has won the awards. And in various events, and our report about the celebration has always been applauded in all past years. And this year too, we have even more participation in these competitive events from various institutes, even from Indian, despite COVID-19 pandemic. In the theme of harm and benefit, we have overwhelming participation in all the categories. So we have 140 candidates in different events, like 48 in the artistic poster, 24 photography, 7 movies, and 61 essays. Of the World Bioethics in Nepal and head of this Nepal unit, this has been a proud moment. The process of motivating our students, the young professionals, to think, study, and express about this very different creations. They participated in various programs, even during this trend and wave have been spreading, and hope that it will keep on spreading across the country. So with the support, and so this has been the reports that we have been producing for the World Bioethics Day. And so with the support and encouragement of all concerned, including our institute authority, global network, and the unit members, through our unit and student wing members and all well-wishers, we trust that our unit will be able to execute its future plans soon. So our unit anticipates for the inclusion of the bioethics, ethics in all health science curriculum of Nepal. So O.P. Koirala sir is there, who is very active in including this bioethics in the curriculum in this part. And so we also anticipate for that. And we very much, and also training of our health science students in the line of the objective of the network in international, and also our Nepal medical, nursing, and other professional council in local perspective. Also, we are anticipating for the training of the health science professionals and teachers. And for that, so there is a dialogue going on with the Professor Russell D'Souza, and also the establishment of the more units in Nepal. And for that, our Russell sir is encouraging us. And so we also anticipate extending the student wings in more and more institutes of Nepal. So there has been the one more initiative in recent years, which is quite evident in our reports. And we anticipate for more collaborative works with other unit members and the teams. We also hope that the needful support from all of you will continue with the more support for this unit to survive and grow more. So today's seminar series under bioethics and COVID is another milestone for this unit. It is in fact a great opportunity, and I take this opportunity once again to thank Professor Russell D'Souza, Department of the Education of UNESCO Chair in Bioethics, for this association. And we have 3 eminent expert speakers, including Professor D'Souza himself. He is from Australia, and Dr. Ved Prakash Mishra sir from India, and Professor Principality Ma'am from India, to throw light on 3 important topics. And we have got the very respected O.P. Koirala sir, Mary Matthew, and our Dean of Academics, Professor Shivendra Jha, to kindly address the gathering. So I'm sure this seminar will definitely help us move forward in this COVID period of the dilemma in various aspects, including bioethics, by providing the forum for the solidarity. So through collaboration, communication, and cooperation. So in today's seminar, and also in the network of the voluntary participation and contribution for our ethical present, society, and future, I invite and welcome all of you to join, participate, and contribute. So once again, welcome and thank you from this is our current committee and myself. So thank you.
Thank you, sir, for having the detailed activities presentation which we have achieved so far, and highlighting on the plan that which we need to be fulfilled soon. Thank you, sir.
Thank you.
Now, may I take opportunity to invite Professor Dr. Mary Matthew to address on behalf of Asian Program of UNESCO Chair in Bioethics. Professor Dr. Mary Matthew is a professor in pathology, coordinator Center for Fetal and Perinatal Pathology, Kasturba Medical College, Manipal Mahe, Karnataka. She is also head Indian Program UNESCO Chair in Bioethics, Haifa, and International Council member, Department of Education, International Network of UNESCO Chair in Bioethics. Philip Femmer Fellow in Interprofessional Education and Practice, member of Towards Unity for Health Network in Social Accountability, and she has research interest in pediatric pathology with special interest in fetal autopsies, renal pathology, gynecology, oncology, and bioethics. And she has published more than 100 papers in national and international journals, and had completed 13 research projects funded by national and international agencies. And she's currently involved in research project validity of minimally invasive tissue sampling in determining the cause of death in stillbirths and neonate due to neurological insults in the brain, funded by Bill and Melinda Gates Foundation. So I welcome you, ma'am, and now invite you to address the gathering.
Thank you,
Over to you,
Professor.
ma'am.
Thank you, Professor Sami. And I won't take much of your time because I know you have a long session. But just to congratulate the Nepal unit. Nepal unit of the UNESCO chair has been so active. When you compare it to all other units, they've been there practically for every conference, for every session, for every World Bioethics Day. They take part in numbers, and it's so lovely to see when Professor Dhanaratna was showing us the report, the amount of activities that are taking place just in one unit is just amazing, and the involvement of the students also is quite amazing. So I congratulate your unit and your dean, Professor Jha, for taking the cause of bioethics forward. And this will have a good impact on your students. And as Professor Kalra said, it has that your college is the one that has molded his son. And we are seeing the fruits of that even when you presented the report, about the number of publications and number of activities that all of you are doing is just amazing. And I really want to congratulate you, because it's not a small feat. It's really something to be really proud of. So thank you for inviting me to. I just want to say congratulations, and I want to wish this webinar a success. But one thing I do want to mention, and I want to give you an analogy of the shepherd and the sheep. Now, all this wouldn't have happened if it wasn't for one man. And I think that man, all of you would agree, is Professor Russell D'Souza. He's just like a shepherd, for him, he's concerned about all his units. And I know many of you who have worked with him or have come across, at least spoken to him, but he will always make you feel special, and he will never leave you out in any occasion. So in this COVID-19, during this pandemic, he's been running these webinars day in and day out, and we've maybe had about 50 webinars. Practically every Sunday we have one with a particular theme, and he has kept us all connected. I'm sure you agree with that. He has kept us all connected, And he has linked us to the main cause of what UNESCO is about, and it is solidarity and getting through this crisis as together. So my appreciation and admiration for Professor Russell, he just goes on, and while we all fall by the wayside, he just continues to go on. But he's truly a shepherd who has brought all of us together. And these webinar series have not only kept us connected, but we are learning. We never stopped learning during this pandemic, and that is the good thing about holding all these webinars. So to all who are taking part, that is all our esteemed panelists today, Professor Kalra has also becomes a very active member of our team, and of course Professor Ved Prakash Mishra and my friend and Professor Princey. We all come together for a common cause, and during this COVID-19 pandemic, to stay together and to learn, to continue learning. And that is what is more than important. So I congratulate this unit, and I hope your students will win much more accolades than what you've already achieved. And it's just marvelous just listening to you and your report. So congratulations, and thank you for this opportunity.
Thank you, Dr. Mary.
Thank you, ma'am, for such a wonderful word of appreciation. Now, I'm privileged to invite Professor Dr. Russell D'Souza, Head Asia Pacific Division, Director of Education and Chair, UNESCO Bioethics, University of Haifa, Executive Director and Dean, Asia Pacific Division, and the International Institute for the Organizational Psychological Medicine. I'm very happy to welcome you, sir. Professor Matthew has just rightly said you are the shepherd, and may I request you to deliver on topic COVID-19 effects on psychological health and healthcare workers and impact on function. So now over to you, sir.
Thank you. Thank you, Dr. Nami. Thank you. I'm delighted to be here, as I said, and we are now starting with our can you see the screen? Are you able to see the screen? Good.
Yes.
Okay. One second. All right. So I'm going to start off today with, we've been talking about COVID and so forth. And one of the important ethical issues, clinical issues, has been the impact on the psychological health of the healthcare workforce and the impact on function. What function? We know that this pandemic has taken a toll. We need a lot of healthcare workforce. And again, this has caused a big issue around the world. And what I'm going to be talking to you will be about more from a global perspective. The emergence of the novel coronavirus, SARS-CoV-2, and the resulting global pandemic have taxed the capabilities of our healthcare systems around the world, not just in the developed richer countries. It still taxed them too. And what we know is the long-term psychological impact of this pandemic on the frontline healthcare workers has yet to be fully understood. And of course, attention to the staff's psychological and mental health and well-being and their function is indeed a critical aspect of crisis management. Now, we talk about infectious disease and the healthcare workforce. These outbreaks pose a unique challenge to healthcare workers compared with other disasters arising from both natural disasters and indeed other disasters. Because here there is a need to protect themselves from the infection with measures such as the quarantine, the use of personal protective equipment, and so forth. The undesirable effects of psychological well-being among the frontline healthcare workers have already been documented. And what we've seen, besides the conventional risk of depression, anxiety, substance abuse, we see distress. And I'm going to talk to you a little bit about the new, from a psychological aspect, what we are beginning to see, distress and moral injury, and of course, sleep disturbances. Now, this is just a quick slide to show you that studies, Italy, China, India, you could see what is the prevalence of the issues, mental health issues, with in terms of the frontline healthcare workforce. And you'll see in all this distress in all these. And of course, in India, they have the other noted one of stigma too, and of course, perceived stigma. The nurses were the most common population of the study, followed by doctors, particularly in India. So we now have enough data and evidence in terms of this problem. Now, this is this slide, which you could see clearly shows a Chinese study, a cross-section, what we see conventionally, what we expect, depression, anxiety, insomnia. But we see distress. Distress is something that's been repeatedly coming up, and I want to talk a little bit about this as we go through this. Now, there's another issue that has come up called the post-traumatic embitterment disorder. When stress makes you bitter, the embitterment disorder, which was initially from Berlin, from the Linden and so forth, we now are beginning to see the post-traumatic embitterment disorder in comparison to other mental disorders. And bitterness seems to arise from situation or life events that are perceived as unjust or a threat to one's basic belief system. Its emotional quality is a mixture of anger and hopelessness, and the person starts to put the blame or puts the blame on external situation, but gives up hope for any change. And so we see this now has appeared in the post-traumatic embitterment disorder, applying to a person experiencing, witnessing or being directly confronted with highly traumatic events, such as loss of significant others, serious illness, disability, and emotional abuse, and so forth, leading to chronic feelings of embitterment, anger, resentment, irritability, or rage, and obsession, and sometimes compelling desire for retribution. These are some of the more rare, or at least we're beginning to see this. And this is not something that has been seen in all disasters and so forth, and epidemics and so forth. Now, I was talking to you about this important issue of moral injury in healthcare workers. I'm going to show you some evidence from the data that we've come across. You can see experiencing moral injury in the frontline workforce, moral injury in times of COVID-19, moral injury in the Chinese health professionals, moral injury among healthcare workers during, and of course, limited moral injury in healthcare during the COVID-19. So we've seen this. Now, what is moral injury? I want you to ask you to look, to reflect on what I'm going to take you through. An emergency room in a COVID hospital, imagine being a healthcare provider. This is required to triage COVID-19 patients. You're inside a crowded emergency room, deciding which of your two patients will get your emergency room's only remaining ventilator. Something that even in the developed world we've had to deal with, right? Although you understand the situation requires you to give the ventilator to the person with the highest odds of survival, yet you were not trained to make these kind of decisions. You always had resources to equally treat all patients. In this scenario that I'm describing, both patients died, despite one having been put on the ventilator. Now, what happens here? You end up with wondering whether you made the wrong decision. Could the other patient have survived with the ventilator? You're racked with guilt, replaying this scenario over and over, analyzing how different choices might have given you a different outcome. Your distress becomes overwhelming, so you bury yourself in work, but the pain follows you home. You avoid genuine conversations with your family, peers, and even try to distract yourself at the expense of routine that were once meaningful. You tell yourself that you followed the protocol, you did the best you could, and yet you feel you violated your moral values. My colleagues, that this scenario is precisely the context in which moral injury may develop. Although little is known about moral injury, we've all known about moral injury in military populations. This has proved to us, COVID-19 pandemic has made it clear that moral injury is relevant, extends indeed beyond the battlefield. And it's natural that in response to these potentially morally injurious events, people experience moral emotions like guilt, shame, disgust, anger, contempt, as well as the cognitive related to blaming themselves or others. So moral injury occurs when these painful moral emotions and cognitions are avoided or suppressed, resulting in greater suffering that negatively impacts the person's ability to function effectively. And yet we need those frontline healthcare workforce never before as we need now with the number of cases and the number of shortfall for beds and so forth. So what they found that social, psychological, and even spiritual suffering, often patients with moral injury seem to be finding difficulty in meaningfully engaging in valued areas of life, as I've mentioned here. Now, we talked about all the studies are showing you moral distress and moral. So what's this moral injury, moral distress? Moral distress and moral injury appear to be very similar since both are related to moral suffering. However, what appears to mainly distinguish the moral injury from moral distress is when a death is associated with the incident. And this happens so often for the frontline healthcare workforce. On the other hand, moral distress refers to moral dilemmas. We all know facing the moral dilemma every day, and this is also called moral disequilibrium, and it's experienced often by multiple mundane incidents that the frontline healthcare professional frequently experiences during their line of duty. To this end, moral injury, for instance, may be experienced with intense feelings of guilt, shame, frustration that a healthcare worker may experience, often to death, and whenever they have death related to the incidents. Okay, and importantly here we see that moral distress and moral injury are cumulatively intertwined and eventually lead toward trauma, which then leads on to compassion fatigue, PTSD, and so forth. These are some of the things that have been identified with our current COVID-19. Moral distress and stress. Now, this is an important issue. Mundane, small micro events that cause moral distress result in what is called a moral residue. And we know from the studies that's been done that there is there's a continuous moral residue keeps going up, and ultimately you have a buildup of unresolved conflicts within the clinician. And this leads to what is called tolerable stress. You know that we have good stress, which improves productivity, but there is conditions like this that has a residue buildup, causes what's called tolerable stress. Now, tolerable stress responses are more severe, frequent, and sustained, and the body responds to a greater degree and with biochemical responses, and also have the potential to negatively affect brain architecture. So I was talking about tolerable stress. Now, what about chronic moral distress, moral injury? And what we now know is there is another stress called toxic stress. Moral distress, morally intertwined, and has been experienced with the healthcare workers. It leads to compassion fatigue. And when you have continuous experience of multiple critical incidents that lead to experience of moral distress, moral injury, we see chronic toxic stress, also called as oxidative stress. And what we now know is that toxic stress results in a prolonged activation of the stress response, and there's a failure for the body to recover fully, and it affects the neuroendocrine immune network. The response leads to prolonged abnormal cortisol response, and of course results in dysregulation of the immune system, including toxic stress associated with persistent inflammatory state. And we know that this is believed to play a role in the pathophysiology of depressive disorders, behavioral dysregulation, psychosis, PTSD, and all those areas. But this is an important thing that we are learning now about toxic stress. Now, changed practices due to this pandemic will inevitably result in tensions. What type of tensions? Clinical ethics versus public health ethics. Best medical practice versus resource scarcity, having to manage with scarcity. Expert practice versus practicing at edge, or at times beyond our competence because of the shortage, and so forth. You have to practice beyond your competence at times. These tensions generate moral dilemmas with high likelihood of causing moral distress, and that is what we showed you in the studies, all having distress. Moral distress occurs when external or internal constraints preclude the performance of an ethically appropriate action or choice of action. And when we have multiple experiences of this moral distress, it results in what's called moral residue, or a buildup of unresolved conflicts that, of course, makes future scenarios that create moral distress not less tolerable. And so we see an impact there. Now, the other thing that has been found, and here's a study by the journal, Medical Journal of Australia, another study with Australian National University. What it's found is the term presenteeism. That means the workforce are not on leave, they're not sick, they are at work, but unable to perform to their optimum. And that has been described as presenteeism. And what they've seen, have you heard of absenteeism? But presenteeism is where you actually are at work, genuinely wanting to work, but cannot do your function is impacted on. And you see the study they showed in a view of 500 people from worldwide, 99.2% healthcare workers were left who went to work with minor psychological issues, anxiety, including fatigue, reduced appetite. All these impacted on not only they had more low morale, they're feeling obliged to show up at work even though they were not 100%, but very importantly, increasing errors, mistakes at work in healthcare that becomes a costly affair, or impact. So presenteeism essentially means that when employees are at work in body, they are not necessarily there in mind. When mind is impacted, errors creep to work. And in the area of healthcare, the clinician making errors or work errors is a significant issue. So this is another area that has been found. So there's a whole area on how do we cultivate moral resilience, fostering self-awareness, developing self-regulatory capacities, developing ethical competence, speaking up with clarity and confidence, finding meaning in the midst of despair, finding meaning, engaging with others, participating in transformation and learning, and importantly, contributing to a culture of ethical practice. This has been found to be important in building resilience. So, and of course, when we talk about managing it, we talk of managing distress. There's some treatments, programs which they've started looking at treatments, and of course, they learned early intervention, tailoring interventions for these populations, and of course, the existing some of the existing treatments, acceptance and commitment, spiritually augmented cognitive behavior therapy, and adaptive disclosure. These provide some promising foundations for such tailored approaches. So I leave you with that. I thank you very much for listening to me. Thank you. And I'll leave you there.
Thank you, sir, for enlightening us with the very pertinent topic, psychological health and moral distress during this pandemic. Yes, all of us are going through in another degree during this pandemic, and how we have to be resilient to give the better care to the patient. Thank you. Thank you, sir, once again. May I now
Ma'am, please unmute. Sami ma'am, please unmute yourself.
Okay. Thank you, Russell sir, for enlightening us with the very pertinent topic and highlighting us how to be resilient during this pandemic as a health professional for giving the better care to the patient. So now may I request Professor Dr. Ved Prakash Misra, Pro-Chancellor of Datta Mega Institute of Medical Science, Nagpur, India. And he is also the principal advisor to Honorable Chancellor and Krishna Institute of Medical Science, deemed to be University Karad, India, and National Head of Academic Program of Indian Program UNESCO Chair in Bioethics, Haifa, member of the International Committee for Bioethics for Asia Pacific region, Director Professor in Advanced Physiology, Professor of Eminence, Excellence, and Emeritus with 5 Health Science University in India, and board member of many esteemed universities and other councils of India. We are happy to welcome you, sir. And now may I request you to deliver on topic COVID-19 and bioethics in medical curricula. Welcome you, sir. Over to you.
Thank you very much, ma'am. I deem it my great pleasure And in all humility, I acknowledge to participate in this international seminar organized by the Nepal Bioethics Unit under the aegis of UNESCO Bioethics Program Haifa. I record my compliments, thankfulness, and gratitude to the unit as a whole for taking up this mantle of responsibility and steering it so well. Our esteemed mentor, respected Dr. Russell D'Souza, the learned panelists and the inaugurator for this workshop, my learned brother and Honorable Vice Chancellor of B.D. Sharma University of Health Sciences, Rohtak, India, respected Dr. O.P. Kalra, learned Professor Mary Matthew, learned another panelist, Professor Princi Palati, my dear brother, Dr. Derek D'Souza, Dr. Shivendra Jha, Dr. Dharmendra Shatya, and the learned moderator, Madam Lama. Ladies and gentlemen, at the outset, I would like to convey to all my Nepalese brothers and sisters greetings from their brothers and sisters located in India. Joining this international webinar, independent of the COVID times that we are talking about, the main concern that we need to really harbinger in our minds is how exactly we should be in a position to train our trained health manpower in the context of all vital important arenas of bioethics and professional ethics alike. This is significant in the context of certain parables which I am wanting to draw very neatly and succinctly. When we talk of humanism, when we talk of human dignity, when we talk of equity and equitability, when we talk of justice, when we talk of availability, affordability, accessibility, when we talk of absolute concerns which can be taken to be autonomy of the individuals as human beings, where exactly is the modality where we are expected to be ensuring all these cardinal principles which make you and me as individuals belonging to civility, belonging to humanity? Is it possible without what I cumulatively call as ensuring that we are able to humanize the medical profession? And therefore, the core consideration which I'm wanting to woo my entire depiction on this topic is humanization of the profession, of the humans, by the humans, for the humans, in the name of humanism, humanity, in the total interest of men and mankind alike, totally based on the concept of absolute beneficence, no non-maleficence, justice, dignity, equity, accountability, responsibility, and how exactly that is required to be achieved. When we believe, and the global charter put across by UNO in 1948, contemplating human dignity and human rights, the mother repository, where from the UNESCO charter that we are espousing for, bringing out the entire cardinal principles of ethics, bioethics in general and professional ethics in particular, linked with the Helsinki Declaration, contemplated in the context of biological research, being in absolute conformity with the bioethical principles governing the same, and then the Belmont Report of 1979, which brings out into the consideration for the global knowledge that ultimately it is the humanities which are required to be integrated with the professional sciences in order to make them humanized, in order to make them relevant for the entire social purposes through socialization. And therefore, ladies and gentlemen, the cardinal consideration which I'm wanting to be driving point at home, be in the COVID times, be in the times before COVID, be it in the subsequent times, and if I'm permitted to say so, be it for all times till eternity or till a new human dimension is created, ethical principles covered within the trinity of ethicality at one hand, morality at the second hand, and value-based ethos at the third hand, constituting that golden triangle in which the entire humanistic ethos is to survive. It is in this context, ladies and gentlemen, the core considerations which were put across way back 5,000 years before by the great Greek philosopher Socrates, who contemplated that ultimately men and women have to develop moral competence. And that moral competence alone will be kept giving them the capacity to answer moral questions, moral posers, and moral problems and dilemmas which will be raised. What he contemplated then, as depicted in the Greek philosophy as an approach for orientation on these considerations, he said, it is necessary that society, in terms of entire facilitatory mechanisms, which is cumulatively designated as Socratic epistemology, gave a way, gave an approach, and that approach was moral case / moral issue deliberation through an approach or methodology of dilemma method for the purposes of discussion in terms of the core considerations and value ethos of the society as the central law, and thereby tagged with societal conventions, beliefs, traditions, and the interest of the society being paramount. It is this Socratic model of Socratic epistemology which ultimately brings us to structuring of the ethics in a way whereby it becomes a societal jewel, whereby it turns out to be not just a matter of teaching or learning, but it turns out to be a way of human life as a whole, and that is the core consideration. It is in this count, ladies and gentlemen, it is imperative that health, which we contemplate as not just a human right in terms of the global charters, but health as a fundamental right which is required to be accrued to every global citizen in this country beyond the realm of any differentiations of any type, any marginalization, or any exploitation of any nature, which the Indian Constitution very categorically defines in terms of the ranges and the scope of discrimination which has to be avoided, that there cannot be a discrimination on the basis of sex, caste, color, creed, religion, faith, belief, nature of worship, occupation, trade, vocation, commerce, and geographic location. It is that equity which is contemplated thereunder. How exactly this health as a fundamental right is required to be accrued to all citizens? It is through an aegis of effective healthcare delivery system. Who is to shoulder the responsibility of this effective healthcare delivery system? The trained healthcare personnel, and therefore it is the training and orientation of trained healthcare personnel to be worked out within the contours of bioethics and professional ethics, so that they are trained, articulated, chiseled, shaped for the purposes of carrying the mantle of responsibility on their shoulders, ensuring that the professional practice generated out of their hands will be totally humanized and will be totally socialized. It is in this context, ladies and gentlemen, incorporation of bioethics into the structured medical curriculum for teaching learning, a reference to which was made by Dr. O.P. Koirala sir in the context of the initiative taken by the BP Koirala Institute of Medical Sciences as early as since its days of inception. In India, I have to record my sense of gratitude to Professor Russell D'Souza, in whose company myself in my humble capacity as the chairman of the Academic Council of Medical Council of India took the responsibility of structuring the competency-based curriculum and the affective domain or the cognitive domain in the curriculum in the context of ensuring that we are able to incorporate behavioral professional competencies specifically thereunder. We aimed at creating what was then designated as an ADCOM module. And the ADCOM module, which we had envisioned before the academic council, was where AT stood for attitude and COM stood for communication skills, and we had readied it out. It was at that particular point of time, just as mundane mortals meet an angel, my mundane mortality met an angel by name Dr. Russell D'Souza in 2015. And it was out of that discussion, ladies and gentlemen, I would like to put it across with all humility at my disposal, that ADCOM module, which we were about to adopt, he ensured that it got converted with an incorporation of a small little E, and the ADCOM became ADCOM module, where A stood for attitude, ET stood for ethics, and COM stood for communication. And that is exactly how the ADCOM module, on incorporating the entire competencies in regard to attitude, behavior, communication, bioethics, they have been appropriately incorporated into the undergraduate competency-based curriculum, which I had the fortune of heading the academic council for readying it. And today, from 2019-20 onwards, it has been implemented across 600 and odd medical schools in India, and it is in vogue. And therefore, I am here to record my sense of gratitude to this cardinal change which we were able to effect under the aegis, guidance, and inspiration of Dr. Russell D'Souza. In order to just give you a brief account of what the ADCOM module is, ADCOM module, we have incorporated 27 competencies through modular teaching, in which it is run across 4 phases in the undergraduate curriculum. Phase 1, we have 5 modules to be operating on. Phase 2, we have got 8 modules to operate on. Phase 3, we have another 5 modules. And phase 4, we have 9 modules. I'm not going into the details of it because we have worked out a comprehensive document on it. But we have worked out even the teaching hours allocation thereon. The total teaching hours which stand allocated to the entire structuring and operation of the ADCOM module in 4 years duration is 140 hours of teaching, wherein the ways of teaching, the modes of teaching, the teaching learning approaches, the entire gamut of teaching tools, technologies, case studies, demonstrative studies, everything has been worked out, including the specific learning outcomes and the nature of the meeting out of the outcomes linked with periodic and summative assessment thereto, with accruable weightage being put across to the entire incorporation in the curriculum. Knowing fully well that ultimately learning is driven by assessment, and hence every inclusion that you want the learner to learn, it has to be linked to assessment. And therefore the hour-wise demarcation which has been worked out in 4 phases is, in phase 1, 34 teaching hours have been allocated. In phase 2, 37 hours have been allocated. In phase 3, 25 hours have been allocated. And in phase 44 hours have been allocated. The main concern that we have tried to address on the entire thing is that ultimately that the attributes that we talk for an undergraduate registered medical practitioner is no more your and my choice and liberty. The international charter has defined, to which all of us as countries are signatories, that what exactly are the goals that we are wanting to be creating for the medical professional to be created out of undergraduate medical program. What are the attributes that we are expecting out of it? They have been prescribed by the world, and we are all signatory to it. And rightly so. The vision statement of the BP Koirala Institute, a reference to which was made by my esteemed brother, Dr. O.P. Kalra, is nothing but what is reflected into the global charter. We have categorically said that ultimately the registered medical practitioner, through the undergraduate training, teaching and learning program, has to have certain qualities. And those have been put across as the character C is expected to be created out of 4 incorporating C's. 1, he or she has to be competent. Then this competence has to be blended with confidence one part of the story, ladies and gentlemen. The competency is the cognitive competence. The competency is the psychomotor or the skill competence. But then there are other two important C's going to balance the C of confidence and competence. And which are those C's? Those C's are pertaining to there is no use and utility of a confidence arising out of total competence if the same is not embedded in a sense of concern and the outproduct thereof as an outcome of compassion. Therefore, I am saying that the character of the physician which is required to be created out of the graduate medical education program has to be that of a confident physician, a competent physician, but more than that, a concerned physician and a compassionate physician. With 5 attributes that we are putting out as an outcome, naming very categorically that he has not only to be a good clinician, he has to be a good professional, he has to be a good communicator, he has to be a leader of the health team, and he is simultaneously required to be a lifelong learner. How exactly these 4 core objectives and 5 attributes are going to be generated? And therefore, I put it this way. The 4 distinctions can be balanced into the 2 pans with the character that you are wanting to be generating into the health professional as a fulcrum. On one pan is the confidence and competence, but on the other pan is the concern and compassion. And when this gets balanced, then what is required to be desired? Taking the mantle of responsibility of the healthcare delivery system through the practicing of the profession, which is humanized in nature and which is socialized in character, turns out to be a real asset in the name of humanism, extending legitimate accruable benefits, totally committed to the ethical principles of profession, being extended to people beyond any considerations of any differentiation, demarcation, distinction, segregation, or marginalization. It is that, ladies and gentlemen. And therefore, this is exactly the plan which we have tried to work it out. And I'm so very happy that we have launched it and it is going on successfully. However, it is imperative that we have to make them very loud and clear that when we are, it is not just that we are wanting to go in for covering the curriculum and working out the competencies for the purposes of their practicing. We will have to make it very clear to them that there is a conflict. Whether they have taken into consideration the concept between healing and care, that is a conflict which has to be resolved when we are wanting to be putting across. What exactly will be the role of empathy vis-a-vis balancing with equipoisoness and equity? That is the second concern which is required to be answered. And therefore, ladies and gentlemen, I trust and believe that in tandem with UNESCO Bioethics Chair, Department of Education, Asia Pacific Division under the inspiration of Dr. Russell D'Souza, we have been able to structure this appropriately and it has been put into motion in India. I have a small little further submission to make. As the framer of the same, having realized and upon detailed discussion, I felt that even the ADCOM module, in terms of the inclusion that we have tried to work out in the competency-based curriculum, we still have not been able to go in for total conformity with the various principles incorporated in the UNESCO Charter. And therefore, ladies and gentlemen, I tried to work out the same analysis through a doctoral degree research through one of my learners. And today we are out with those particular findings where we have brought out that there is a need where we would like to make the present ADCOM module incorporated in the Indian curriculum, designated as competency-based undergraduate medical education curriculum in terms of a updated, modified ADCOM module, so as to be in total tune with the various governing principles governing the profession in the bioethical UNESCO Charter, which is a benchmark document. And therefore, the addition that has been incorporated is on 3 important counts. The total 140 hours, we are not changing the phase 1, but in phase 2, there are 2 important things which we would like to add in terms of the update through incorporation of 2 competencies, resulting in addition of 12 hours. Number 1, bioethical principles in the reflection of the historicity there too, important. There is a need that the learner should be in a position to be oriented with the historicity of it. how exactly the bioethical principles governing the humanism came into force, and how exactly they have been put into operation over a period of time, and their present relevance is most important aspect, which in the present model it was missing, and therefore that is a suggested update which I'm wanting to advocate. If you take it in the third phase, there is something which still I found missing. The important three aspects. Number one, handling of the confidentiality in certain defined illustrative context needs elaboration. And therefore, a competency on that has to be added in the third phase. Declare disclosure of the medical errors. When you talk of accountability, when you talk of honesty, when you talk of patient's autonomy, when you talk of justice, then the mandate in terms of the disclosure of the medical errors, they turn out to be one of the hallmarks in terms of the cardinal principles of the UNESCO Charter, which needs an appropriate incorporation and therefore another addition of the competencies. And the third important aspect is duty dispensation is not just the core and ancillary duty dispensation. It also incorporates the dispensation of what is designated in the legal parlance as, quote, fiduciary duty, unquote. And it is the dispensation of that which also needs to be brought out under the rubric for the purposes of ensuring that the training and orientation on that count is clarified. Therefore, in third phase, what we are advocating is that 2 more competencies are required to be added. 4 more competencies are required to be added, resulting in addition of 24 hours more. So phase 2, addition of 12 hours, phase 3, addition of 24 hours, and phase 3. There are certain inadequacies so as to be covering in terms of ensuring that it is absolutely in tandem with the UNESCO Charter principles. Therein, 3 important additions have been conceived. Number 1, ultimately, we will have to clarify in regard to various ethical dilemmas. Today, the COVID pandemic really has brought into acute focus of all of us, several dilemmas, ethical in nature, how exactly they are to be handled. Therefore, illustrative modes in regard to handling of the ethical or in regards to the judgmental creation onto the ethical dilemmas, including dilemmas which are created during the period of an epidemic. That is another important illustrative connotation which are required to be handled. What exactly will be the relationship between the professional and the industry in the context of various scientific researches to be carried out, sponsored in character, including declaration of the conflict of interest. That is an arena which is required to be touched. And lastly, apart from that, dealing the death is yet another arena which needs to be covered and which needs to be clarified in all the relevant details. And therefore, in phase 4, what we have tried to work out is addition of 4 more competencies and therefore 24 hours, and thus 12 hours in the second phase, 24 hours each in third and fourth phase makes a total addition of 60 hours more of teaching, making the entire bioethical dimensions, including attitude, including communication, including behavior, to be covered in 4 years through 200 hours of teaching allocated to it, with the modes, manner, approaches, tool, technologies, modalities, and link commensurate modes of attachment incorporated therein. I have no time to work out on those details, but at some time I would love to discuss that with all concerned. But that is exactly what is the update we have been able to suggest. And that, in my opinion, will go for really making the curriculum absolutely internationalized in the context of it being commensurate with the governing principles of bioethics incorporated in the UNESCO Charter. And in case, as and when we are contemplating the entire credit system to operate the internationalized undergraduate medical education, on these count, the credit transfers also will become easy, facilitatory, and significant. Having said so, ladies and gentlemen, this I take as one part of the story. That the present generations, through this curriculum, we will be teaching, training, and orienting them. But there is a vast multitude of people like you and me who are in the profession and who were never oriented with the structured format on this count. For them, what is the modality? And therefore, my humble thinking, which I'm wanting to put across to all concerned on this count, is that we need to work out capsulated modules on bioethical teaching, training, and orientation, on covering all the vital aspects. And when we say that there is a need and there is a restriction in regard to that registrations granted for medical practices are not to be permanent, They are to be reviewed. They have to be revalidated. And though the period of review and revalidation can be country specific. In India, we have put it across to be every 5 years that renewal is required to be done. And for that renewal, the condition precedent which is put across is that you and the concerned practitioner has to gain 30 credit hours during the period of those interim 5 years. My proposition therein, that out of these 30 credit hours, 10% of the credit hours should be attributed to bioethical areas of concern, consequence, and relevance. And therefore, earning of the 10% of the total credits for every renewal of registration would be a mandatory must in the context of ensuring that the various bioethical concerns to be inbuilt into the professional practice, they are not only got oriented, but various arenas which require to be worked out in elaborative details are also made known through capsulated modular teaching, duly accredited and certified in nature and character, in which the integration of medical schools with professional associations would also be a modality which can be worked out, which I am working on. What I am wanting to put across in this limited time, ladies and gentlemen, is that a good exercise has been done. A venture has been undertaken for the purposes of ensuring that streamlining of the bioethics in terms of teaching and training through standing curricular inclusion is worked out, and it is a great going. Whatever update, it needs to be periodically updated, and that is exactly another task which we have tried to work out. Lastly, my submission is, finally, this is not something which can be dispensed only by structuring into teaching, learning, curriculum, but we will have to work out the modalities of ensuring that this goes and it percolates down to all the registered medical practitioners across any and every country in whatever modality the country may deem appropriate, so that we are able to go in for global humanization of the medical profession and global socialization of the medical practice. Thank you very much for patient listening. God bless you all.
Thank you, sir, for highlighting us in detail about the curricular process and development, including the bioethics in medical curriculum. Yes, for the humanizing the medical profession. And we want to congratulate you for this innovative work. And we also inspire for to review and include the bioethics in our curriculum also. Thank you. Thank you, sir. So now let me introduce Professor Dr. Princey Louise Paletti, Head Integrated Curriculum UNESCO Chair in Bioethics. And Professor Paletti has earned her graduate MBBS, postgraduate MD in pharmacology from Goa Medical College and PhD from Open University, Sri Lanka. She is fellowship in International in Nature of Organizational Psychological Medicine, and she is avid researcher in around 7 lakh with the grants, and she has over 90 publications to her credit and 23 textbooks, chapters, and 2 textbooks. She is a pharmacologist, bioethicist, and medical educationist. So may I now invite you, ma'am, to highlight on the topic ethical implication in COVID vaccine development and distribution.
Webinar.
Over to you, ma'am.
Yes.
Good evening, everybody. At the outset, I would like to thank the host of the day, Dr. Shakia and Dr. Samia, for a wonderful hosting and doing such an important work in the times of COVID. Despite the pandemic times, you all are doing such a wonderful effort forward. I also would like to thank the Vice Chancellor and the Rector of BPKIHS University in Nepal. I would like to thank mainly our Dr. Russell D'Souza, who is known to have Russellized the world with bioethics. Our good friends, Dr. Mary Matthew, who's the head of the Indian program, and I'm happy to be sharing the stage along with Dr. O.P. Khalra and Dr. Ved Prakash Mishra. They are the legends of our times, and we are really happy to see them together, and my good friend, Dr. Derek D'Souza too. And I cannot forget Dr. Rupa Sharma. We have gone through some blizzards and snowstorms and run around the countryside for a conference in bioethics, and there was a blizzard and we had to come rushing back. So we have fond memories. Yes, ma'am, I see the activities of your unit over the years has been wonderful. So I would like to get into the topic that is we are talking about the COVID vaccine and the ethical considerations in the development and the distribution of this. One second. Yeah. So all of us, the question is, when is the vaccine going to come? That is what we all are asking, everyone asking, because even if not the treatment, it is repurposed drugs to the, that has come to the flow, and also vitamins and being in the sunlight and good food. And these are the aspects that are going. So vaccine to build up the herd immunity or the population immunity is the only succor that we have. So friends, in these times of need, how should a vaccine come? How fast it should come? And how can it be done in an ethical and right way that we have the guarantee that this is safe and effective for use? I know there is a lot of apprehension in people when they hear from their social media and other unwanted sources of information to say that, all these studies are being expedited. So that'll be at the compromise of something. So let us discuss a few of these problems in the ethical aspect. I wouldn't be going much into the scientific aspect, and let us come to some consensus on these aspects. So friends, because of this problems that are arising, the WHO has brought forth many aspects that are important at this point to note. There is a consortium that has led to the formation of target product profile that is giving you the exact minimal product adequate profile that is needed for any vaccine to have. So also there is a vaccine landscape that draws out the process informations for the 2020. Also, there is a vaccine trail that has been put up that is showing you the solidarity vaccine trial that is allowing for expedited, agile information. So this is one very important aspect that is happening. So this allows for a vaccine trial to be run in parallel and not in, one after another as the sequence. Also, we have the ACT, that is the Access to COVID Tools, ACT Accelerator, that is all the resources, all the materials and information that is needed for the treatment, diagnostics, and vaccines are in a pooled area from which any country, everyone can have access to. That is the ACT that has come through. And also we have the Gavi, the WHO and the CEFP that has drawn out how to access COVID vaccines before by the end of April 2021. That is one more aspect that has been brought out. And also there is this vaccine allocation guidelines that has already been framed before the vaccines are out and ready to be delivered. So friends, we are looking at a grim period of 34, as of October, these details which I'm talking from WHO, 34 million cases with 1 million deaths. We know how vaccines are being used and how effective it can be. But today, an apprehension, a suspicion arises in our minds when a patient who has, a person of COVID disease, who has undergone the disease himself, symptomatically and asymptomatically, but was COVID positive, those very persons, after 4 months, they are back again with the disease. So the question of the vaccine is also a suspicion in the mind of the public. So when we see how the vaccines work, how do the vaccines work? You and I are aware very much how we use live attenuated vaccine. Of course, you can use inactivated dead COVID vaccine, right? You can use a viral vector, wherein a protein, the gene that codes for the specific protein of that pathogen protein is coded for. And we all know which is the protein that we want in the coronavirus. It's a spike protein. So mostly to the spike protein we have, these are safe viruses into which we inject this gene so that they produce that protein and they develop. And this is a safe virus. So you can have viral vector or viral platforms. You have live attenuated dead viruses. Then there is another important point, which is a novel technology not used hitherto in any of the vaccines. Since Edward Jenner brought in vaccines, we are come to a new end at this point in 2020, where we are looking at nucleic acid, the gene, the nucleic acid chain that codes for a particular nucleic acid. That code is put into is given to is injected as a DNA plasmid or as a mRNA. And this will develop immunity. So that is how we can see vaccines work. So this nucleic acid one, this is a novel technology that we are using, and the scientists are overwhelmingly enthusiastic to seeing that this would be clicking. Okay, so that is what we have at work, the viruses at work. So we have how the viruses are delivered. We come to the delivering of viruses. The vaccines can be delivered. Mostly it needs multiple dosage to be complete memory, or we have to give it by boosters. But now we are trying to get down to single dose or maximal 2 doses are being advocated, and that is how the research is turning out now. So there are many immunogens that can be used. If you see here, these are on the left, you see the various immunogens that are used as vaccine tools. So friends, we see the various steps of vaccine development. We have about, there are about in the preclinical phase, as of October, we have 151 candidates in the preclinical phase, edging to come out. We had 10 vaccines in the phase 3 trials as of October 2020. And these 151 candidates we have seen mostly up to now over this 1 year, we have over the 2020 scientists and doctors and physicians, we have all learned, and we are putting together at a breakneck speed and learning a lot of items. And one of them is that despite having so many vaccines coming out, only 7% has succeeded from the preclinical trials. And those that have entered into the clinical trials, only 20% is the success rate. So friends, we are in a quandary, but we are looking forward. Another aspect I would like to highlight in the steps of development of vaccine, there is the aspect, because of the compromised state of 9 months instead of the 12 months. And in the phase 3 year to get, that is a time period has been shortened. And also we see that the number of cases in phase 3 should be 30,000 or more. So all these means we need to have a lot of machinery in place to do all these kind of things and come out with a successful eureka, and there is this race is not only on a scientific turf, it is now a race of the countries. And it has, since economics has reared its ugly head into it, now it is an economic race with the global recession and everything coming on. The country that gets it is going to get it all. So we have to have guidelines in place. So friends, the development of the COVID vaccine, the stages, and because of the shortened period and expedited review, do not worry, we have the post-marketing phase. That is, before in this, we have a human challenge part. That is, after the phase 3, we give it as a human challenge. Now, this has brought on a whole load of ethical tumult, because should you expose normal individuals who have taken the COVID vaccine, expose them directly to the virus? So is that ethical or not? These are questions that are coming to the fore in our minds. So friends, the post-marketing surveillance has to go very, very securely and in a meticulous manner for the effectiveness of this vaccine. So these are things that we can predate and tell. So we see the ethics in COVID-19 vaccine. It's definitely we need to have the ethics because of so many conflicting principles that are coming through. So many conflicting principles. So we can draw a line at, I would just like to tell you some aspects of we have in Elsevier, one of the Elsevier publications, Clinical Acta, they have brought through ethical and organizational considerations for mandatory COVID-19 vaccination in healthcare workers. This is a lovely read for us. So also they're asking, it is ethical. They have categorically stated that it is ethical to use highly promising vaccines as opposed to less promising vaccines. I mean, it is logical rather than just ethical. Now we come to the aspects. I would like you to just go through into these aspects. How will we, when the vaccine is ready and developed fully, it's almost at the end stages of readiness. So we have to have a resource, how to give this vaccines distribution. Ethical aspects do arise. So one of the aspects is the ethical considerations that should be going through prioritization. Now, we have many aspects to be considered. One is equity. One is equity, how it should go to all. And another aspect is about the best outcomes, the utility, in whom should be given. So as of now, the vaccines, when they bring, the WHO has promised by 2020, by the end of 2021, they would be distributing at least 2 billion vaccine doses. 2 billion. And what is the population of the world? Approx 7 billion. So still 20% is still at large. It's only 20% that will be addressed. And it has been deemed ethically considerate to give it to the frontline workers, especially healthcare workers or the police and others who are involved in direct contact. So these are the aspects that should be considered. So here we see in the next slide, I would like to show, we can see priorities for the worse off, those who are worse off. And also we can see the prioritization for those who are asked and seeking with others. So all these are the aspects. I can go into the description and into the these aspects would be taking too much of your time by the end of this day as it is drawing near. So I would just expect us to understand and know the concepts behind a prioritization. So friends, these are some of the aspects that I brought through, but there are many other issues that are related to the vaccine, how it will be distributed and developed. So friends, these few aspects I have concluded in telling you, but there are aspects of transparency. Transparency is a very important principle that is held of high value in research and in ethics, bioethics. It is also, we have to know about the inclusiveness, who should be included, who should be let out. So they say frontline health workers as well as the elderly senior citizens, they may be given the, but inclusiveness with informed consent. Some people may not want to take that risk of the vaccine itself. Then how do we handle? So in all this vaccination, we are ultimately also building up the herd immunity, the population immunity, and we are preventing, if a large number of the community is vaccinated and immunized, even those who are at the end of the Gaussian curve, at the outliers, those who are immunocompromised and very young, they also are offered protection if the whole herd immunity is present. So that is the reason why vaccination is seems to be the answer, and that's when we can get out of this, out of the clasp of this pandemic. So here we are working hard at it. So consistency of the vaccines, consistent efficacy. We have a lot of apprehensions, as I had brought out earlier. Accountability. Now, for everything, accountability is an important factor that needs to be said, and I have jotted down some of the points that are to be included when we talk about accountability in vaccine. Also, here is another aspect about what is the rationale for the prioritization. So we have the three groups here and the rationale for it. I hope you are in agreement, and you would see most of the journals have come out with, fast track. They are taking fast track manuscript submissions, and 2,000, instead of expecting some 500 or so, there are 5,000 research papers coming to the flow in all the journals. And all the journals, what they are solved, have the pandemic COVID era. And so there are so many researches going on. In fact, we have put in NAC also one specific area of COVID research, and they are asking those aspects, COVID research, So these are the points, And I should like to also inform you, in our research team, Dr. Russell's team, we have Dr. MS Baliga, who's also featured as one of the 2% in that article that had just come out and hit it. Dr. MS Baliga, who's on our team, Dr. Russell has brought in him from Mangalore. He works at the Mangalore Institute of Oncology, and he's one of those researchers. So being good researchers, having all these factors of integrity and all the aspects should be, these are the scientists and researchers who are in the forefront of development of COVID vaccine, and also doing so much other impacting and relevant research. So friends, I have taken you through most of the aspects, and I would like to end this session. I hope we have understood how the development and how the distribution. These are the only two areas I have touched upon, and we can see the interaction of the ethical principles vying with us. Another important principle that I didn't bring about is the dignitas persona, where to do the viral testing, vaccine, especially viral vaccine testing, like for Salk and Sabin polio virus, we had used the HeLa cell line. Now here they are using fetal cell lines. And so there are some religious objections coming through because they are using aborted fetuses cell lines for these kind of work. So there is a whole tumult of ethics happening there. And you and I, as ethical researchers and physicians, we have to unravel this mystery and use it for the best of mankind, ethically and safe. Thank you all.
Thank you, ma'am, for giving detail on process and development of vaccine. And yes, of course, the world is waiting for this vaccine to come soon. Thank you, ma'am. So with this, we are at the end of the all the presentation. Now the time for question and answer session. And if you have question to the speakers, so now you can ask the question. And if we have any questions in the chat box, let me check.
I think Dr. Kishore has one question.
Okay.
He asked, in India, how many research centers are working to develop vaccine? I think Professor Princey can respond to this.
Yeah. Put my video on. So friends, I am not exactly aware, but many of the COVAX virus center, Oxfam, all these Oxvac vaccines, there are centers, and many of the from Bombay right up to Delhi, there are clinical trials being conducted too. Even in Kerala, we have in Trivandrum clinical trials being conducted. In the development process, it is, I am not aware, but I can get back to you on this. I know about 2 of the vaccines that are being tried, and it has reached phase 3 trials in India. This is all I'm aware of.
Yeah,
So,
thank you.
yes.
And I think I saw one question, quite ahead. Let me just check.
Yeah,
so
I
this is
think
again
Sekhar
about the,
Khatioda.
yes, go ahead, ma'am. Yes.
Sekhar Khatioda has asked, when COVID infecting us in transmitted to some animals like it has been transmitted to mink in Denmark, in such transmission the virus gets mutated. Might it be beneficial for approach to make vaccine? I think this is again for the Princey ma'am.
Yeah, the mutation of the coronavirus, in fact, all of the viruses have this tendency to mutate. That is their inherent capability, like Darwin's theory, that is their way to survive, So that is an inherent trait of the viruses. And talking about coronavirus in particular, yes, it is said to have mutated and come to this stage where it is affecting human beings, and it can be transferred from here. So again, the validity of the vaccines, all these aspects come to the fore, So that is the reason why we need to have ethical deliberations while we are looking through. And as they mutate, they may become worse, or they become more or less passive. So we are not sure. We are still in a state of uncertainty. We are not knowing what we are looking at. In fact, we had written an article in which we had drawn a picture of the coronavirus as the white elephant, and all the 7 blind men are touching it and saying, this is this, this is this. So, sir, my questioner and myself, we are touching different angles and trying to come to a conjecture where there is no certainty. So we keep our eyes and ears open and an open mind, and we try our best in making the educated, calculated guess. Thank you.
Thank you, ma'am.
Yeah, still I see other questions related to vaccine. So one question asked quite privately was that when we can anticipate to get the vaccine. So this is from one of the media friend. So I think this is again will be better addressed by Princey ma'am only.
Well,
Yeah.
I can tell you the vaccine. I was at the meeting with Fossey about a week ago from US. I mean, he's probably the one who's got the best. And they are, well, this was at Melbourne University, the meeting. He's expecting it by next month. Or next month, the Pfizer, which is I think RNA, DNA, that one with Pfizer, and I think there are 2 that he expects. I mean, he's probably got the best knowledge of what's coming. There is, of course, the other Chinese one, which is already there, but that's what is it? Killed virus, no? So it's probably less than 50%. That's what they think, like the flu, influenza virus. So that's what they say. But by the time it then getting the phase 3 completed, again, the AstraZeneca Oxford has moved to human challenge trials. So they're doing it all over. But after that comes the scaling up. So it'll be approved. Then scaling up takes, because they have to commercially manufacture it. No, so there's a scaling up period. So that's what they say, but we'll have to see.
Yeah.
All right.
Yeah. Now, in continued, I think in the same line, there is a question: when actually this vaccine will reach to the poor countries, like
Well,
countries?
that's the. I think I gave a talk on that a few days ago, and this whole area comes under. The world leaders have made a lot of promise. There are some issues there. There were many people are committed. Some of the philanthropists, some of the companies. But the million-dollar question is, which of those candidates are going to become successful? So those who have promised to give everyone, if their candidate does not, vaccine does not become successful, so this is an issue that there is that COVAX, which is what is promised by the WHO syndicate. Australia has given 150 million, and that was meant for to be given and shared. Again, it's not going to, when you say poor countries, even the poor country, there will be a vulnerable, who is more vulnerable. It's not going to be given, because it's, even if they're giving, there's a manufacturing, transporting, the freezing, the temperature. There's so many, areas, and which of the countries have the regions have got the ability to give all these requirements. All this has to be worked out. That's the scaling up, the transport. Some of those ones have to be kept at -20, and all those type of things are there. And then we have one dose, 2 dose. What's the type of a number of things are there? Yeah, but there is certainly. They've had some meetings. I can't remember, but yesterday or 2 days ago, I think I gave the actual meeting where leaders came together and wanted that everyone should be guaranteed and all that.
Yeah.
And COVAX was started for that reason, no? They were to make sure all get it.
Countries.
Yeah. Okay.
Yeah. So rather than the ethics related, there are many other theoretical questions. It's probably not ethical one, but still related to the vaccine ones. There, of course.
Yeah, that's a very that's a very interesting. Everyone want to know a lot about the vaccines. The different types and the and also in fact, some of those are the first time, as Princey said. Even the one that Pfizer's, that's the first time the biotech companies. Is that the which is with one company? Which one is that?
Nucleic acid one, the mRNA one.
mRNA, is that the Pfizer one? Pfizer is another one. Yeah, Pfizer is another one, which is using a recombinant RNA or DNA, one of those ones. All these have got, and then again, there are people who question what is the effect of this in terms of gene manipulation and into the DNA and so forth. So we don't know, but they say it's all already. Even the people are interested in knowing this, because all are waiting. The AstraZeneca Oxford, they had transverse myelitis. Now we know that transverse myelitis, multiple sclerosis is one of the things that's accepted, that they will expect. But it's a question of whether it's 1 in 1 million or what. So they've now moved to human challenge trials. Okay, that's That's good. So I think that we'll keep it to the ethical issues here.
Yeah, yeah. So of course there are other questions. So I think we will stick to the ethical questions as Professor Russell said. Uh, so uh, if yeah, I think if we keep those questions, two questions I see aside, like for example, one question from Ayusha Kesi: does COVID-19 has any chance to produce auto antibody and autoimmunity? So it's again ethical question. If we can respond,
Well,
Professor Kesi. Yeah.
the antibodies, yes, that's what they're doing. And that's the question that we're going to be looking for, whether it's producing the antibodies, and that's what they're doing. In fact, we've got now one Australian case is there where they've got a second infection, a second time. So they've got a few cases where people have got it for the second time and third time, which is another question altogether. So all these are areas that are being still, we're not sure, because after the stage, the 3, we need to look at whether the efficacy, whether it's going to be 6 months, whether it'll be 1 month, 1 year. No one has yet come out with definite, how long will this last for the immune, we've not reached that stage. Yeah, Prince is saying stage 3. All are in stage 3 except the Chinese and the Russian ones. But the Russian one, they skipped stage 3. They did away with that. So, what we have, we're talking now about only the vaccines that are in the FDA, European, where that regulatory body is looking after. That's what we're talking about. If you want to know, the Chinese have already, it's already out, but we're not, and they're not giving much information except that they've given it to the army, they're giving it. But my understanding is that it's a killed vaccine, no? So it's like the flu influenza vaccine. It has a 50% or less thing, and we're not sure about. But of course, if you have a killed vaccine, you're going to get less side effects. You're not going to get too many problems with it. Whereas all the others, which you're talking of nucleoside with our DNA, all the others have got other using other protein. So those are the areas. Okay. Anything else?
Yeah.
Yeah,
Can
I
I
think
just add one more point about the human pooled antibodies that was being recommended as a therapy? That has failed. It had come up through. Yeah, that is it.
Yeah, it has never been proved, and failed because you're talking about the other trial. Isn't
Yes.
that what you're talking of?
Yes,
Which
yes.
for the 4, and again there the question is that they didn't recruit many African, South Asian, those country people, but any of 3 out of the 4 have failed. That was the four treatments that they were looking at. Those 3, I think they've released it 2 weeks or 3 weeks ago. So they've stopped that one. Yeah.
I think there is one question which is not related to vaccine here. So there is one question which seeks for the elaboration of the moral distress. Probably Professor D'Souza will.
What is the question?
The question is just, sir, did you told about moral distress? So the
Yes,
question is, yeah.
Yeah, what is the question? Moral distress is all the studies. I showed you the studies. China, all of them have got distress, and moral distress is moral injury. Moral distress is something new that we have seen. It is not generally seen in epidemics and disasters. It is something that we've seen known from the battlefield, coming back from war. But for the first time, we are now learning that beyond the battlefield, moral distress, moral injury. Moral distress, probably the moral injury is related to when there's a death, when there's a moral issue, moral dilemma that you're facing, and that results in death. That leads to moral injury. But the important thing of all this is that moral distress and moral distress is every time you face a moral dilemma, you have even microscopic small things. Not enough this, not enough beds, not, these are small. You make a moral decision. I'll do this, I'll triage, but it ends up with what's called a moral residue. But I think the important thing here is that it leads to toxic stress. Toxic stress is the impact of oxidative stress, which leaves you in a permanent inflammatory state with cytokines, lymphocytes, and that leads to autoimmune disease, all the chronic illness, including cancer, depression, and so forth. So that's what is the worrying, the long-term effect. So the concerns are, what is the long-term effect of all this on the the human, the healthcare provider? This is why they found it with the doctors and nurses predominantly.
Okay. Sir, I could see one more question related to stress. This is asked by Amrita Bandopadhyay. She want to ask, is there any way out not to become stressed?
Yeah, I gave some. I gave. It's called moral resilience. Okay, if you take the American Nursing, you just go on the web and look at the American Nursing Association. They could have, because they have got probably the most. They've written about, studied a lot about the moral distress, and they've got how they're teaching the nurses how to be morally resilient. And I gave some of those points in my in my presentation, telling you what some of the things you need to do. But one of those important things was also the place of fostering self-awareness, self-regulatory capacity, contributing to a culture of ethical practice, participating in transformation learning, engaging with others, finding meaning in the midst of despair. These are developing ethical competence. Now, these are all the what has been shown to improve moral resilience. Okay, so that's the area that, and also there are some 2 or 3 treatments, but one of them is the spiritually augmented CBT. They talked of 3.
Good evening.
Yeah.
May
Okay.
I
Anything else?
may I draw just to one link that I have shared in the chat box also. We happen to publish one stress management, a way ahead. So this article might help you in this very question. So you can refer to one of the link that I have shared among many. So one about the stress management, a way ahead. So I think I have discussed many of those strategies in that. So thank you. I think, ma'am, you have a
Yeah,
question.
I could see the hand raised by the Dr. Hemsankar. If you want to ask a question. Dr. Hemsankar, are you there? No.
Okay.
Oh.
Yes. There are
Yeah,
other
this is
questions
not.
also. So one question is from Srijan Gautam. So he asks, with lots of anti-vaccination influences emerging every day, what can be the ethical approach as a health service provider to address this issue?
What?
It's a question for all of the
Go ahead,
speakers,
sir.
I think. Yeah.
For those who are saying they won't take the vaccine, is it? Is that what you're saying?
Yeah, anti-vaccine.
Yeah.
Yes. How we help professionals to address that issue?
Well, that's a difficult issue because they are exercising the autonomy, and the only thing is that you can on the harm principle you can use it, but we are not sure whether it will mean general good. Whether supposing you get the side effect, we know that all of these have got what do you call it? Possible adverse events, including autoimmune transverse myelitis, multiple sclerosis, all these things. So I don't know if anyone would force them to take it. That's against their So it's a question of, general good, the harm principle. Is that right, Princey?
Yeah,
That's
that
harm,
is
the
Mill's
harm
harm
principle,
principle.
Mill's harm principle, where you curtail someone's autonomy in the interest of a general good, or but we must be sure of who decides what is good. The question is what's the decision? How do you say that that's good? If I get the multiple sclerosis or whatever, multiple myelitis or whatever. So the question is, it's a quite difficult area to actually force. I don't think anyone other than probably China and Russia can do that, where there is not necessarily autonomy is always the state has supersedes the autonomy in those in that type of system. So you can only explain and put it to them, yeah. But we have the same we have the same problem now with polio, with measles. We've had outbreaks of measles because of people refusing to. Australia's had outbreak. They refuse to take. So the same with polio. Even polio has come back because of that.
So similar question is here. Use of trial of the drugs like remdesivir, plasma, hydroxychloroquine, etc. has been rampant. How do we decide on the use of trial drugs ethically? So maybe similar approach to address.
Yeah, but those type of things who have to fulfill the research, that they all have to go through the ethics committee and our regulatory IRB, and the IRB has been given that ability or to decide whether it's ethical, just like a human challenge trial. Is it ethical to infect someone and a healthy person? But the WHO has given on the 6th of May, they've said it is ethical. They had a number of ethicists came together and they made a statement. So there's a question in all this. So as far as the trials, yes, the research, COVIDization of research, all this has happened. But ultimately, that is something that the research committee has to look at the validity of that research and if it's meeting all the principles required, ethical principles for research. Yes, and one of those is equity in burden and benefits. All research, whether that's happening or not, is another question in COVID. Are they so people are there must be equitable sharing of burden and benefits. So the research committee is expected to check that before it approves it. Yeah.
Okay, I think Professor D'Souza has already explained about the effect of this moral injury to the common people, I think. And then there is again the question about the herd immunity. So it's more rather than ethical.
Princey spoke about that in a talk. Herd immunity. Again, the question of herd immunity is also controversial. There is a question of whether there is such a thing called herd immunity, because there is one herd immunity when you get a certain amount of vaccine population that's received a vaccine. But in this context, people were talking about herd immunity from letting the people get infected. And Sweden, initially UK, they followed that principle, which is questionable ethically, because you let again, it's a utilitarian model where you let the infection go, and those who survive and become they become resilient, and those who don't will be die. And so that was called, but technically it didn't work out. Sweden has not worked. This time they have gone to lockdown. So wherever they tried that, but herd immunity per se comes, that term has come only when we talk about vaccine, where you get herd immunity, which was achieved in smallpox and all these areas. Yes, but herd immunity, what was being talked about let everyone get infected. Those who they will get hurt. That is not technically acceptable. So that term itself is being used loosely.
Yes.
Okay, is that all? So shall we call it? We'll give it to
Sorry, ma'am.
to yeah.
Okay. Thank you, sir. Thank you, ma'am, for addressing all the issues and queries raised by the participants. So before ending the session, today's session, let me allow to propose the vote of thanks to all the eminent speakers and all other personality who have contributed so generously to make this event come together smoothly. I would like to express my gratitude to the Professor Dr. Russell D'Souza sir for his constant support and mentoring us since inception and planning for this program also and enlightening us with his valuable talk. Thank you, sir. I'd like
Thank
to
you.
convey my sincere thanks to Professor Dr. Dhanaratna Sakya, Head Nepal Unit of UNESCO Chair in Bioethics, for chairing the session and for presenting the report. Sir has always been driving force to move our unit ahead. Thank you, sir. I also take the opportunity to thank Professor Dr. O.P. Kalra sir for having inaugural address and taking us down the lane of inception of BPKIHS. Thank you, sir. We are indebted to Professor Sivendra Jha, Dean Academics BPKIHS, for addressing the gathering on behalf of BPKIHS Nepal. We owe our gratitude to all the eminent speakers of today's program, Professor Dr. Mary Matthew, Professor Dr. Ved Prakash Misra, and Professor Dr. Prince Paletti for enlightening us with their valuable talk. Thank you, ma'am. Thank you, sir. And many thanks to all the participants from Nepal and across the globe for their active participation and having put the queries. Without your participation, this program would not have been possible. Thank you all. Hope all of you took the message and joined the mission of bioethics in days to come. Thank you once again. Thank you to all. Okay, before ending the session, I would like to request to put on video to all of you to take
Camera on,
the
yes.
group picture. Yeah, camera on.
All the participants to open
Yeah.
the camera.
Kindly put on your camera. Yeah. I guess it's done.
It's done.
Okay.
And
Thank you.
thank you.
Okay.
Dr.
Thank
Ved.
you.
Thank you.
Thank you.
Thank you.
Sami.
Thank you,
Thank
everybody.
you, Dana.
Yes.
Thank you, Derek.
Thank you, sir.
For and Princey. Thank you very much.
Congratulations, everyone. It was really good and wonderful to be here.
Thank you. Thank you,
sir.
Dr. Derek. Yes.
Not at all. Not at all. My pleasure. My pleasure.
Thank you,
Thank
Dr.
you to all.
Shakya Sami.
Yeah. Thank you, ma'am.
Thank you,
Thank you,
Dr.
Dr.
Sami.
Russell.
Thank you all. Thank you all.
Bye, sir. Bye-bye, everyone. Thank you.
Bye-bye.
Okay.
Bye-bye.
Thank you,
Bye-bye.
sir. Bye-bye.
Bye, Ved Prakash sir.
It's 12 o'clock in Australia.
Oh, good night.
Oh. Almost
This is
midnight.
usual time for Dr. Russell. He has to be here with us.
This is still
Yeah.
Okay.
Thank you so much.
Thank
sir.
you. Thank you.
Thank you so much.
Bye.
कोणाचा नंबर नागपूरची आहे का लागून नाही राहिलं का ते नाही लागत आहे थोडी इन्क्वायरी करायची